So the first slide, of course, is a joke slide, and but it sort of isn't, because the one thing that's pretty universal is everyone's against taking drugs, medicine, drug-free America. Take it, and the other punchline is that usually you only take medicines if you need it. So that's sort of the issue here. I can't tell you how many parents, when they come in with their kids to me as a psychiatrist, beg me not to make their kid into a zombie. That's like the first line. I don't know if that happens to other doctors. You go to your cardiologist and they accuse him of some atrocity even before he met you. Anyhow. So, yeah. Oh, okay. Yeah, I was, while we were waiting, I kind of told him. Okay.
So if you don't know me, I'm Andrew Bauman. I'm the president and CEO of NIFAC, most of you do. Dr. Eric London is probably one of the premier psychiatrists in the country in terms of treatment and working with children and adults with autism. He's been doing research for I can't tell you how long. Eric, together with his wife, Karen, in the 90s, created and started the first National Alliance for Autism Research, which they founded and started here on the East Coast in New Jersey. And together with John and Portia from the West Coast, who did Cure Autism Now, both of them kind of were gobbled up by Autism Speaks when they came around. But Eric still works for New York State, OPWDD, in the Institute for Basic Research. And I think we know each other over 20 years at least?
No, at least, yeah.
At least. And I'm just so thankful and pleased that he would be willing to come and do this for us. We are live webcasting. So if you have a question and you don't mind, you can just go to the mic and ask the question so they can hear you on, wherever, who's ever watching. If you're shy and you don't want to be on camera because there's a camera on the mic, we can just hand you the mic and you can ask your question. And you don't have to be on camera if you don't want. So I'm going to turn it over to Eric. And again, thank you, Dr. London, for being here. And enjoy.
Okay, so the that's not true of take it. So you have to deal with that. And then the last one is a big issue in the autism world, which is simplicity. In other words, will they be able to get it down? Some things come in really big capsules. Some things you can chew, some things you can't chew. Some things are liquid. Some things come in patch. So not infrequently you have to make your decisions based on what's even practical to get in. Okay, so this says discouraging data on the antidepressant. That's another joke. But again, it's not really a joke because there are tremendous difficulties in evaluating medications and how they work. And I have some firsthand experience with this. Number one, there's a lack of good studies. There's a lack of double-blind studies. And as we go through different medicines, I'll be telling you which one have good studies. Most of them don't. Most of the drugs that we use are not well studied. There's a lack of appropriate rating scales or endpoint targets. So about a year ago, 2 years ago maybe, did you all hear about the mGlu-R5 inhibitors for Fragile X? Did anyone hear about that? Okay. So I'm not going to, I wasn't going to talk about it as such, but Fragile X, is big overlap with autism. And, they have, because Fragile X is a known genetic illness, they have really good animal models. They can make Fragile X mice. And they found a drug that would actually cure the mice. And everyone's very happy. This is the greatest thing in the world. And some of the really big drug companies were running to make drugs, with this model. And we actually, in Staten Island, we actually were involved in two of the studies. One was Roche and one was Novartis, which is big international companies, put hundreds of millions of dollars into this. And the studies all failed. So I spoke to the scientists at these drug companies, and what they basically told me was, everyone got so excited so fast, they said, go do the studies and we want to get this to market. But they really didn't know what to measure. So there's not going to be a pill in my lifetime that you're just going to take and the whole thing is going to go away. Now that may be true for a mouse, but I think for humans that's not something we really should be thinking about even. All of these developmental disabilities are collections of different problems. And so it's not, we're used to thinking in medicine that you get a diagnosis and you have a disease. So the good one is strep throat. I mean, strep throat's a really good disease. You have strep, it's in your throat, you take antibiotic, it goes away. It's a really nice model. We have nothing like that for anything that has to do with the brain. But nevertheless, the medical field still thinks that way. And not only does the medical field think that way, but the FDA acts that way. They act like if we're going to have a drug, it's going to have to, cure it. And I'll talk about that a little later too. Another problem is the developmental nature of the disease or the disorder. So, as the affected person ages, the symptoms change. So what symptoms are you really targeting? Well, at age 5, you have symptoms that you probably don't have at age 12, and you're not going to have at age 25, but you may get new symptoms. So the question is, are we going to develop treatments just for particular age groups, or, okay. Then add on the spectrum disorder end of it, and that's another really big problem. By the way, I have 2 articles that I wrote in the last couple of years basically saying autism should not even be a diagnosis. It's too variable. We're stuffing too many things into the little basket and calling it autism. And so then the problem is when you try and do a study, say, okay, will this drug cure autism? Well, I think we're piling 100 different disorders into the little basket, maybe not 100, but a lot of disorders into the basket. And of course, any one thing you do is not going to work for everybody because everyone's different. Okay, lack of pediatric studies. It's very hard to do pediatric studies because IRBs, you know, the institutional review boards, they want to protect their safety. So they pretty much make you do it on adults first before you touch the kids, which makes some degree of sense, except we generally never get to the kids. So even if we get some studies, they're usually done on adults. But then we don't learn about the kids. And by the way, the kids, all right, I'll just throw this out now. I have a theory that what we call autism starts before you're born, but it continues to develop throughout life. And if you could arrest it early on, a lot of the things we see wouldn't be there. Which I was telling some of you who were here before that, most of my research now is on babies, because I think if we can identify which babies won't do well and we can then start to look for treatments on those babies, by the time someone's an adult, you know, you're trying to reverse a big process. Lack of clinical centers. We don't have a Sloan Kettering for autism, do we? You know, everyone goes and we want, well, the latest will happen. Those things don't exist. They probably don't exist because of financial issues, Medicaid. Medicaid doesn't pay much. As a matter of fact, even probably the two most prestigious programs in the New York area for autism, which I guess would be Cornell and Mount Sinai, they don't do treatment. They will assess you and they will allow you to be in a research protocol, but they won't give you ongoing treatment. They'll send you to, you know, a private doctor or something. And then the last thing is the prejudice against the use of medications, and I was talking about that also. There's a lot of negativity about the use of medications, which make learning about it very difficult. You'll hear a lot about evidence-based. So you know, in the medical profession, we really believe in evidence-based stuff. So we want trials that really test whether the drug works or not. The problem is anecdotes are usually misleading. So while you may want to, you know, if you're a parent, you may want to listen to other people's anecdotes and try what they tried. As a doctor, you can't really do that because you'll be giving a lot of people medicines that don't work. And it's very problematic. So you'll see anecdotes till the cows come home. I've been doing this for many decades, and I could tell, you know, so many things have come and gone in the years I've been around. Okay, but then people will tell you there's no evidence that this works. No evidence doesn't mean it doesn't work. Okay, that means maybe they haven't tested it, maybe they haven't tested it adequately. So that confuses the issue too. Another one is that the failed trials may be misleading. So even if you do a good study, so let me go back to that Fragile X stuff. There were some Fragile X people in the studies that seemed to do very well. But when we compared it to placebo, it washed out. Okay, I believe, and I think most of the people involved, that there was some of the kids were benefiting from it, but because we didn't know exactly what to test and what the outcomes were that we needed, it was a failed trial. And by the way, the drug companies have dropped these drugs because we're dealing with big business here. So, or after pumping in a few $100 million into some drugs, and if you get a couple failed trials, they're not going to keep pouring more and more into it. So we may have lost some very good drugs because we didn't know how to test them. And then the last one is there's no one autism, there's many autisms. I guess, I hope everyone knows that. What did I do? How do you go back? Oh, yeah. Okay. I'll go through this really quickly. Sometimes you'll go to the doctors or psychiatrists and they'll talk about dual diagnosis. So that comes from the intellectual disability world, where if you have intellectual disability, that's not a psychiatric diagnosis, and don't you dare say it is. If you have a behavior problem, if you're depressed, if you have any of that, you have a second diagnosis. It's not the developmental disability. I think in autism that's just utterly crazy, because 80% of autistic people have second diagnoses. But it's the philosophy. Um, okay, so dual diagnosis, your child may get one of these diagnoses, and I think I don't think it's even valid. I mean, I'll give you an example. And I have OCD down there, the fourth one down, obsessive compulsive disorder. So autistic people are very repetitive. Are they OCD? No, not really. They don't respond to the same medicine. So the serotonin reuptake inhibitors, which work pretty well for OCD, don't work well for the repetitive behaviors in autism. So even though the symptoms look the same, and then there's a big debate about whether or not attention deficit disorder is comorbid. That's the word we use, comorbid with autism. Again, I think almost every autistic person I've ever met has attentional problems. So whether or not it's the same as attention deficit disorder, I don't know. I can go on and on with these, but okay. So the way I tend to do it is I treat symptoms. So people come to me and they usually complain about one of these things that's up here. Sometimes other things, but this pretty much carries most of the weight. And obviously some of these things are more difficult than others. Something like self-abusive behavior or aggression needs treatment pretty intensively. Something like inattention is not such a big problem, but may respond to treatment. And I put up the neurotransmitters just because, you'll hear about them. Serotonin, norepinephrine, dopamine, acetylcholine, GABA, glutaminergic, and other peptides I wrote there. And I'm going to give you some examples of all these things in terms of the concrete drugs that we use. Okay, so I'm going to start with the antipsychotics. And these are probably the most effective meds that we have for autism. Two of them are actually FDA approved for something called the irritability associated with autism. And that's as close as we have to anything that's FDA approved. So mostly these things are for treating aggression, hyperactivity, obsessional behaviors, irritability, anxiety, and they're good for sleep. By the way, if you want to interrupt me, go ahead, because it's all right. So how many of you remember this movie? So yeah, this was the one where a bunch of people they got shrunk, and then they injected them into a body to fight disease or something. And so that's a blood vessel in there with their guns, fighting the disease. And the one in the corner there's Raquel Welch. The reason I put this up is because a lot of people perceive these medicines like that, like antipsychotics are in there to fight psychosis, but you see, they're really not. The antipsychotics are chemicals that work on different chemicals in the brain, and the antidepressants don't really fight depression. They are chemicals that work on chemicals in the brain. And so sometimes I say, well, I'm going to give you an antipsychotic, and people say, I don't want, he's not psychotic. So you have to understand that a lot of the terminology we use, just things that evolved, and don't take it too seriously. Okay, so the history of antipsychotics. They were discovered back in the 1950s, and for those of you who know the history, prior to that, when you had diseases like schizophrenia, you would end up in a state psychiatric hospital for the most part, and you lived there the rest of your life, and there really wasn't much else. And then they invented Thorazine, the first antipsychotic, in the 1950s, and they started giving it to people, and they stopped being psychotic, and they could go home. That's another story. I'm going to tell you the other story. Yeah, I have to. I can't not tell you the story. So there were about 500,000 people living in state psychiatric hospitals in the 1950s. That was the maximum. So in the United States, about 500,000. They started to notice that these medicines were very effective, and then they could discharge people to the community. And Congress passed something called the Community Mental Health Act. And the Community Mental Health Act said that they will close institutions and they will create supports in the community, supports meaning community mental health centers and housing. Okay? Well, they closed the psychiatric hospitals, but they forgot the second half. So today, we have about 350,000 chronic psychiatric patients living homeless on the street, and we have about another 250,000 living in prison. Okay, now the reason why I want to tell you this is I have this deep-seated paranoia that this is what they're going to do to developmental disabilities. Because they're starting the nonsense about institutions, and everyone's buying into it. You know, I can't believe that people buy into it. They pulled this one off already. But yeah, so I think as a community we need to be real careful that they're not going to forget the second half if they want to close these institutions. We could talk about that too. I had experience in New Jersey when I was working there, closing some of those institutions. It wasn't a pretty picture. Anyhow, in the 1958, they discovered clozapine or Clozaril, which is a medicine that's still around. It's very, very effective. I don't know. I don't use. I have one patient on it. It's used in autism for some very severe patients, but it's got very bad side effects. But it had a different mechanism than the traditional antipsychotics. And then in the 1990s, what we call the other atypicals came, and those are the ones that we use today. So these are the original antipsychotics. You may recognize some of them. The big ones are Thorazine and Haldol. The others are not very well used these days. These are the ones that we use nowadays. So Risperdal and Abilify, the first two, are the ones that are FDA approved for irritability with autism. The third one, Zyprexa or olanzapine, there's not much. I have one slide to show the research, not much research on it. I use it a lot, and I use it at high doses because it works. It doesn't work at low doses.
Which one is that?
The third one, olanzapine or Zyprexa. I'll talk about that individually. Seroquel, there's no evidence about it. I don't think anyone, before I gave this talk, I haven't given this talk in a few years, so before I gave this talk, I went and I looked this stuff up. I don't think there have been any Seroquel studies. Geodon, there's some anecdotal evidence that it works. I do use it. I'll talk a little about it. The next one, Paperidone, is paliperidone. I've never used. It's a kind of a Risperdal spin-off. Latuda or lurasidone I do use. I have about 6 patients on it successfully. They did one study which did not pan out, but I've had some success with it. And then the last one is Clozaril, which I said I only have one patient on it. So I'll talk about the side effects of the antipsychotics. So number one is diabetes. It is a problem. Now, by the time we realized these meds caused diabetes, the question came up, well, maybe that's because we didn't realize schizophrenics have diabetes. But there was actually one study back in the 40s and 50s, and they found that unmedicated schizophrenics did have a high rate of diabetes, they had about 8%. But with the atypical antipsychotics like Clozaril and Zyprexa, we have rates of up to 10 to 15%. So it is a real risk. Diabetes is a real risk, but it's not a terrible thing because you can monitor it. You know, you can do blood tests, and as long as it's good, it's good. If you see the blood sugars going up, it may be time to stop it. Yeah. Oh, well, in that this slide, all the ones on the left are the generic names, and the ones in parentheses are the non-generic names. Okay. I tend to use the non-generic names because they're easier to say. Okay, another side effect with the antipsychotics is weight gain. So again, not surprisingly, the ones that are worse for diabetes are also worse for weight gain. And they can be pretty bad. One study found Zyprexa and Clozaril greater than 20 pounds of weight gain per year. Now, I haven't had that experience with my patients. I said I use a lot of Zyprexa, but I have had a few patients blow up on Zyprexa, and then I stopped the Zyprexa. Yeah?
So after you stop the Zyprexa, the weight gain, will they be lost again? Can they be lost again?
Yes, if the Zyprexa was causing the weight gain, when you take away the Zyprexa, now there is an issue that, like everybody else, you still have to diet and exercise, but most of my patients who gain weight on Zyprexa were able to lose at least most of it.
Yeah, my son was on it for 4 months, he ballooned, and I cannot lose the weight now. I'm trying.
Was he on something else?
Risperidone.
Oh boy! See, if you looked at the next thing, Risperidol, you gain 5 pounds per year. Oh. Did I click something? Whoops. This isn't my computer, so I don't know how to use it. Oh, it came back? Oh, well, this is really bizarre. Oh. All right. See, the problem here is... okay. So, okay, what's fine. All right, so Risperidol, you gain 5 pounds a year anyhow. So it may be causing weight gain also.
But he's been on risperidone for 7 years, so it's probably not from risperidone. The Zyprexa just 4 months already.
Well, but I'm
Gains
saying
30
it
pounds.
may be hard to lose weight on Risperidone. He may not be gaining much weight, but it may be hard to lose it on that. See? Now, under the low, we have Geodon and Abilify, and that's in the literature, but I don't believe what I wrote here about Abilify. I've seen a lot of patients get a lot of weight gain on Abilify.
So today, if they go on medication and it doesn't work, and they gain the weight, and they go off medication, would they lose the weight after?
That was her question, too.
Oh, I'm sorry, I didn't hear what she had said.
Yeah. So the answer is most of my patients who've gained a lot of weight on something like Zyprexa do lose it when I take them off. No. Okay. Well, then I asked her. The next question was, is he or she on a different medicine? No. We still can't lose it. Huh?
I mean, we're not really aiming for the loss, but I was hoping that as soon as they came off of it, that.
Well, I don't think it works that way. I don't think it's like you stop it and the weight goes away. That's what I was saying.
You have to
Diet and
work on it.
exercise, you have to work on it. I know it's a problem.
Especially when they have such food issues to begin with.
Yeah. Well, I actually have an anecdote, so I had a patient who was on Risperidol, and the mother kept saying, it's working great, but he's gaining weight, and then the next time it's working great, he's gaining weight, and then she said, look, I don't know what to tell you. I mean, the weight is just, I don't want to stop it, but anyhow, there was someone made a picnic, all these families with autism, and I was there, and they had a waiter, and the waiter was carrying a tray of food, and I see this kid go charging through the lawn, tackles the waiter, jumps on the tray, and starts stuffing all the food. And the mother was saying, she says, yeah, you see what I'm telling you? So it really can be a big problem. By the way, the original antipsychotics like Haldol don't have as much weight gain as these. And Geodon doesn't have weight gain. I've never had the problem with Geodon. So I do use Geodon.
Is it on the
Yeah, Geodon.
You know, the way you say it is not the way it's spelled up there.
Is that the same as Abilify, the Geodon?
No, Geodon and Abilify are two different meds. The literature says Abilify doesn't have weight gain, but I don't believe it. And then there's... Huh? Well, it's not going to be universal. I mean, look, I have people on...
He exercises and...
I have people on Zyprexa who've never gained any weight, Yeah. Yeah.
From your experience, the most effective and most popular was olanzapine?
No. The two FDA approved ones are the Abilify and the Risperidol, or Risperidone and
I have a question.
aripiprazole. Yeah.
When you say FDA approved, what kind of studies have they done? Is that like a double blind?
Yeah.
It is. And
Yeah, the FDA, to get approved, you have to do a fairly large, good study, double-blind, placebo-controlled study. And as a matter of fact, I think you have to do 2 of them. for most drugs. So yeah, they both passed muster from the FDA, which is hard. It's a hard standard. Okay, so another side effect, cardiac. So I put this slide up. By the way, this is oh yeah, let's do this. Okay. So this is the electrocardiogram, the QRST, and
This goes
I know, but I want the
Oh, the pointer.
the pointer. Yeah.
Yep.
See, it's doing this, but
It's not showing.
it's not showing it. Yeah. Okay. So what we're interested here is the QT interval, and actually it's called the QTC. It's a little bit of a calculation that the machines do them now for us. So, the reason why we're interested is the QT prolongation can be an important issue. There's something called, it's an arrhythmia called torsade de pointe, and it could be fatal. So you do have to be a little careful with this stuff. Now, the significant QTC interval is 500 milliseconds. Okay, so there are people who just naturally have QTC intervals of 500 milliseconds. They're at risk. 450 millisecond QTC interval is an alert. You should be careful with that. The cardiologist might want to get repeated tests. Anything below 450 we usually consider fine. So, all right, this just basically says what I told you. Okay, so this is a list of some of the medicines that we use. So you see the first one is the olanzapine and the Zyprexa. That has almost no cardiac effect. Risperdal, a little bit, quetiapine, Haldol. Then the red one there, that's the Geodon. And that is about 17 milliseconds. It increases the length about 17 milliseconds. It's not insignificant, but it's not a huge deal because most, if you get an EKG, most of the QTC intervals are going to be 400, 410, 420. If you go up 17, you're still well within the good range. Now the last one is thioridazine, or it was called Mellaril in the past. It was a really widely used drug, and it was on the market like 50 years until we figured out that it increased the QT interval that much. Very few people use it anymore for that reason. Okay, this one is just extrapyramidal side effects. You know, the antipsychotics have Parkinsonian type side effects. Most of the newer ones, what this slide is basically saying is the newer ones mostly don't. So Abilify, Risperdal have some. Zyprexa has very little. Quetiapine has very little. Okay, then people want to know whether these meds affect cognition. You know, is it going to make you stupid? So now we don't have that data in autism. I've wanted to do that study for many years. I can't seem to get it done. It's a hard study to do. I have a method that I think might work. But anyhow, this was on schizophrenia, and what you could see actually is that almost all the cognitive scores get better on the medicine. Now that may be because the person's not hallucinating anymore, so it's kind of hard to do well on a cognitive test when you're hallucinating. But my guess is that appropriately dosed antipsychotics in autism probably also help learning. That's my guess. Improperly dosed probably does not help learning. So if you're too tired or sleepy or out of it, it'll hurt learning. So as I've been saying, Risperdal and Abilify are the ones approved, the best studies. Risperdal works at relatively low doses. I talked about the side effects. The one thing I did not talk about was breast growth in males. And you know about that if you watch late night television, because the lawyers are all advertising all night for this. So what happens is when you block dopamine, you get a release of prolactin. prolactin is a hormone that makes the breast grow. So for women, this is less of an issue because they have more natural prolactin. For the men, sometimes the breasts grow, and you get that type of tissue. It's not dangerous, but but the lawyers will sue you for it. I suspect a lot of the antipsychotics do it too, except we haven't figured it out yet. Because blocking dopamine is what does it, and most of the antipsychotics block dopamine. Again, the drugs like Zyprexa less than Risperdal. But it's real. The only so where I work at a place in upstate New York once a week. We have a lot of autistic people up there, and what we do is when the prolactin gets high, we look at their brains and make sure they don't have a pituitary adenoma. If the prolactin is stimulating a growth of something, that could be dangerous. Other than that, it's really a cosmetic issue.
So if the breast get enlarged after you stop the med, will the breast like grow smaller?
Well, I've only seen it once in my career, and that person, the breast went down. I mean, it's not like they grew completely female breast. It was like you see a little budding and that kind of stuff. And then if you notice it, then you stop it. You know, you don't. I wouldn't leave it several years, unless, of course, there's a pressing reason to do that. So the Zyprexa, olanzapine, we talked about it mostly. I think I've mentioned everything on this slide, so we'll move on. Okay, next class of drugs. Yes. Yeah, yeah.
With the Risperdal, I know it comes in injectable form also.
Yes.
Invega, is it Invega Castor and then Trinza? Is that the same?
Invega is like Risperdal, and it comes in
Right, it's a
injectable.
1 month, monthly
Right,
injectable?
Yes.
Is that as effective as the oral medications if you have somebody that's non-compliant and won't take oral medication?
I think it is. I don't have that much experience using it in autism, but I've sometimes we've used it and it works. Yeah.
What about,
I mean, it's the same drug.
right, what about the new injectable Zyprexa?
I have no experience using that. I mean, I suspect that they all work because to get to market, they have to show effectiveness. Usually not in autism and schizophrenia, but they're the same medicines.
I'm talking about other comorbidities.
Excuse me?
Like either for bipolar or schizoaffective.
Right,
or
right.
Any of those.
Well, yeah, it works. I mean,
You know, with somebody who's also on autism spectrum also.
Oh, well, I mean, I guess the answer to your question is if the pill works, the injectable will work.
Okay.
And if the pill doesn't work, the injectable probably won't work. Yeah. Yeah.
One question also, regarding your personal experience or research you might have come across, are there very, the long-term effects of taking Abilify in the lowest dosage, are there like more side effects that were not listed up there before? In your experience that you've seen, I'm talking about long-term, taking it for years.
Okay, so most of my patients are on their medicines for years. Most people don't get to me unless the behaviors are bad. So by the time they come to me, I'm dealing with some pretty severe behaviors, and if I get them under control, people are pretty happy. So most of my patients are on these medicines for years. And except for, the creeping weight gain, I don't usually see more long-term side effects.
Adverse effects of long-term use.
I haven't.
Okay, good.
Now, I've had one or two autistic patients that developed something that looked like tardive dyskinesia. Tardive dyskinesia is a movement disorder that comes from the use of antipsychotics over long term. For the newer ones have a much lower incidence than the older ones, which is probably why I didn't even put up the slide. Or I actually did have a slide, I just glossed over it. But you have to watch for movement disorder creeping up. But again, if you watch for it, you can stop it before it takes off.
What do you do if someone already has it?
Well, if you already have a tardive dyskinesia and you're still on the medicine, well, it's a judgment call. It depends how much you need the medicine. Um, you know, there was an article that just came out about treating tardive dyskinesia. I didn't read it. Not because I didn't want to, because I haven't gotten to it yet. But I don't know if there really was not any good treatments for tardive dyskinesia other than stopping the medicine. And that would be a topic in and of itself. I have some really interesting stuff later on the talk, so I like, yeah.
One quick question.
Yeah.
Previously, when you said severe behaviors, as like some of the long-term effects of those on Abilify, how would you describe those severe behaviors?
The patients that I see who are severe, self-abuse, they bang their head, they're aggressive, they put the staff in the hospital. I mean, yeah, I have patients like that. A lot of these are residential cases.
Is that because the behavior wasn't treated previously and it has escalated, or does it come sudden?
Well, in almost every case, there have been attempts at treatment for years. The treatment for these behaviors is a combination of medicine and whatever you want to call it, behavioral treatment. I don't mean just strictly ABA, but I mean behavioral treatment. And I could also throw in there environment. So where I work, it's in the Catskills. It's a beautiful place. They got farms. The kids are outdoors. They do calm down. Being in a very pristine surrounding is good for your nervous system. So some of the kids right away calm down, we sometimes improve the medicine. Sometimes we need a few behavioral programs. And I don't want to give you the wrong idea. Some of these behaviors go on and we're constantly struggling. But anyhow, okay. So I'll do this. I'll do serotonin drugs. I'll do real quick. So you probably all know the serotonin drugs, Prozac, Paxil, Zoloft, all these things. There was some initial enthusiasm for their use in the autistic spectrum. None of the studies really panned out. They tended not to work. That having been said, I have several autistic patients on these medicines successfully. But probably what I'm treating is more like mood or anxiety. It does not work that well for obsessions or for repetitive type behaviors. One thing it does do is, in some people, it gives you a level of detachment from the intensity of your emotions. This is what it does for typical people. And so my favorite story about this is there was a woman who she had a fiance. He cheated on her, and then the woman he cheated with got pregnant, and then she was really upset. So she was in therapy, but every night she was still living with her fiance. He would come home, and she would stare at him until she lost control, and then she'd jump on him and beat him up. And this went on for weeks. And so when she came to me, I gave her a serotonin drug, Paxil or Prozac or something. And then I saw her a few weeks later, and she came in, and I said, well, you're still beating up your boyfriend. She goes, what are you talking about? And I said, well, you told me you. She said, oh, I threw him out. And I said, well, that's surprising. And she said, why? You cheated on me. What's wrong with you? Well, so in other words, what happened was she was so emotional about the thing that she couldn't think straight. But the serotonin drug calmed her down enough that she said, what am I doing here? And she just did the next move. So these things are like a little bit tricky. I think even with the autistic spectrum, in some cases, it could calm people down. They don't get as excited or upset about some of the things that set them off. And these are the side effects. The serotonin drugs, as a rule, don't have too many side effects. Sexual side effects are a big problem in the typical population. frankly, in our population, you almost welcome it if it lowers their sexual interest. Um, they're sluggish, or you could be sluggish or wired. You can get some stomach upset. And then suicide is, you may have seen that in the press. They did a study with Paxil, and there was a slightly higher rate of suicide than even in placebo. And what happened was, of course, everybody panicked, and they took their kids off the Paxil, and then the suicide rate went way up. So these drugs can cause suicidality, but I think the explanation is maybe some of these were manic depressives and it triggered a manic. I think in our population we shouldn't worry much about these drugs and suicide. Stimulants. Okay, so they're good for attention, hyperactivity. Their side effect profile is pretty nice. There is, like everything else, is cardiac safety. Many years ago there was a report that some medical examiner actually started noticing that a lot of his teenagers who were dying suddenly were on stimulants. When they actually did the study, they found that it was an artifact that just as many teenagers not on stimulants had sudden cardiac death as on stimulants. There have been some conflicting, not only are there conflicting studies, but even the agencies, the medical agencies like the American Academy of Pediatrics, the Heart Association, have actually come out with conflicting recommendations. The most severe recommendations is you should do at least an EKG and a cardiac exam before giving the medicine. And then you can follow them. And some don't even think that's necessary unless they have a history of cardiac problems. So for half America is on stimulants. So, yeah.
Also, my son gained weight because of this antipsychotic. He also has ADHD issues. Should we give him,
To get a good side effect.
so that his appetite will be decreased? At
Yeah.
least he won't gain so much weight.
Well, the good and the bad news is that only a very small minority of people on stimulants lose weight. It affects appetite, but I think it's under 10% of people. And even that 10%, when the stimulant wears off, they can eat. And you can't give it to them at night because they won't sleep on it. So, yeah, so most people on stimulants don't lose weight.
It won't suppress the appetite as much.
It
as
will maybe when they're on it, but again, when they come off it, they'll be
they
hungry.
eat again.
So, yeah. It's a good idea, but I don't think it's... Okay, so these are the stimulants, Ritalin, and there are many kinds of Ritalin, and then I wrote Adderall there, and Vyvanse. Those are really amphetamines, dexedrins and amphetamine. And those are really it. There's really only two major classes of the stimulants. To make a long story short, I think they're pretty equivalent, and some people respond better to one than the other, and so sometimes you can try one or the other. I don't have a strong preference. I probably use them about 50-50. And, well, I probably should say that for autism, there is some good literature using the stimulants, mostly on high-functioning kids who have attentional problems. I don't think of a low-functioning kid who has trouble attending it'll help much. Then there's Strattera. Strattera is a medicine that's FDA approved for ADHD or ADD, but it's not a stimulant. And it's very good in the autism population because it doesn't have some of the side effects of stimulants. No sleep problems, no tics. It's only one dose per day. You can use it any time of day, whereas the stimulants you have to use in the morning. No side effect of anxiety, which the stimulants can have. Most child psychiatrists aren't real fond of Strattera because it doesn't seem to work as well as the stimulants, but I have a lot of autistic kids on Strattera pretty happily.
And what does it actually help with? Like what?
Well, it helps with hyperactivity and helps
Oh.
a little bit with attention and concentration.
So if they have eloping issue, will it help? Like they run away?
Well,
they like to-
eloping could be for many reasons. If they're eloping because they just can't sit still, it might. If they're eloping because they have a sense of adventure, no, it won't, because they want to get out, or
Oh.
in other words, almost all these symptoms, as I was trying to explain at the beginning, are really not one thing. They're different brain problems cause the same symptom. So, if you're aggressive, there may be many reasons for your aggression. If you're eloping, there may be many reasons for your eloping.
Can eloping be a side effect of taking medication? Or it's more
Most likely
behavioral?
not. With the antipsychotics, I didn't mention it, but there is a side effect called akathisia. Akathisia is when you can't stop moving, but it's not an eloping type moving. It's more like you just got ants in your pants, and you kind of squirm around, and they can stay in one place and just keep moving. And by the way, people with akathisia, if you say why you're moving, go, oh, I'm moving. They don't even realize it. It looks really bad. People who have it don't mind it, but I don't think it makes you run.
So what do you do when they have this akathisia?
Akathisia.
Yeah. If they have this.
You probably have to take them off the medicine if it's
And
more than
change
slight.
another
Yeah.
one.
You might have to change medicines. Okay, and then another class of drugs that are well used in autism are the mood stabilizers. Most of these are anti-seizure medicines. The one that's probably the best studied and the most popular is Depakote. I use a lot of Trileptal because it has very few side effects, and I think it works almost as well, if not as well. Depakote and Tegretol are very good medicines, but do have a lot of side effects. Lamictal is very good. It has one Lollapalooza of a side effect, something called Stevens-Johnson syndrome, where your body mounts an allergic reaction to your skin, and your skin starts to get eaten away. And I've actually had 2 cases of it in my career, and both of them had to go to intensive care. So I'm a little gun shy of Lamictal. The neurologists use it constantly. So I have a lot of patients who are on Lamictal from their neurologist, but I shy away from it. Keppra, there was some initial enthusiasm for Keppra. I think Keppra makes you worse in autism. So I would stay away from Keppra if you have the option. Well,
I agree with you.
yeah, I mean, I've seen so many cases when the neurologist puts them on Keppra and their behavior's worsened markedly. Yeah. Neurontin.
Do you have to step down from Keppra?
Well, it depends why you're using it. Again, I've never prescribed it my whole life, so.
Well, he was never on it till, we were on no medications for many, many, many years.
Yeah.
And then anxiety became off the hook and a little bit of aggression. And so they put him on Seroquel
Yeah.
and Zoloft. And then for the first time ever, we were away actually on vacation, and he had a seizure,
Okay.
an 8-minute seizure. He's never had a seizure
Yeah.
before. So we were rushed to the ER, and then in order for us to go home without doing all the testing in Nevada, they put him on Keppra and said, you'll probably get off it when he gets home and he sees a neurologist.
Yeah.
So now we're actually supposed to be putting in the paperwork to IBR and to the Discovery Center to see
Okay.
who can take us, to kind of evaluate all these different things that are going on.
Okay.
So I see exactly what you're saying. I think the Keppra made things a lot worse, and so I've kind of on my own cutting it in half and half, and I just
Well, does he see a neurologist back here?
he hasn't yet because we just got back
Oh,
and
okay.
we're about to.
Yeah, the rule
The
of
psychiatrist basically told us, who was going to be
Yeah.
monitoring all these meds,
Yeah.
said you're better off going to IBR and having a complete.
Okay. The rule of thumb usually is you don't medicate for a seizure.
Right, that's exactly what he said.
Yeah. So a neurologist would probably see him, do an EEG, and unless there was something really bad on the EEG, would probably just take him off.
Right, okay,
But no one else besides the neurologist is going to want to do that.
right.
Okay. So in this list, Topamax is very popular medicine. I think it's popular because it promotes weight loss, although I have not ever been successful, my patients, giving them Topamax for weight loss. It doesn't work very well as a behavioral med, in my opinion. Some people use it. Lithium is on this list. Now, lithium, of course, is not an anticonvulsant. Lithium is a very good medicine. It's not an easy medicine to use. You have to do frequent blood tests, monitor, and there's some long-term side effects that you have to monitor. But I have a lot of patients on lithium, you know, who, remember, again, my patient load is probably a little more severe than most. Yeah.
Can you go back to gabapentin, Neurontin? You missed.
Yeah,
Thank
well,
you.
so, yeah, that's a medication that works on the GABA system. It's a very safe medicine. It's got very few side effects. I wouldn't call it a canon, so it's not one of my first-line drugs. I have a few people who've done very well on it, and at pretty high doses, by the way. But it's got very few side effects, so it's, nice drug.
The reason why I
Yeah.
asked, not because it's not connected to, don't have a child with autism. I take it for myself, for
Yeah.
my back.
Okay.
So, and it works more than any of the other,
Uh-huh.
opioids that
For
the
pain,
shots,
yeah,
yes,
yeah.
they gave me for pain and all those
Yeah,
things.
good,
And that's the one
good.
working for me. That's why I asked. Thank you.
Yeah, okay. Okay, I put this up here just for completeness sake. Has anyone ever been exposed to naltrexone? This was real popular about 20 years ago. There was a big theory that, so naltrexone blocks the opioid system. As a matter of fact, it was FDA approved first for heroin addicts. So you detox a heroin addict, then you give them naltrexone. If they use heroin, they don't get high. So they weren't going to use it. So then someone had this idea that maybe a lot of the self-abuse was because the autistic kids are trying to stimulate their natural opioids, their endorphins, and you get like a runner's high from it. That's the whole theory. That was purely imagination. Anyhow, there were a lot of very small studies, 3-person studies, not good studies, not double-blind studies, and it kept showing that it was working. Then finally, in the 1990s, they did 2 double-blind studies. The only beneficial effect they found in the studies were decline in hyperactivity. Also a drug with not too many side effects, but I don't use much of it because I've had 1 or 2 patients who used it for self-abuse that it actually worked. But everyone's different. Okay. Let me see how I'm doing here. 8:10. Okay. So the vole, is he a good husband or does he do one-night stands? And the difference is his oxytocin. So this is the work of Tom Insel, who actually just last year stepped down. He was the head of the National Institute of Mental Health. And they put together this really nice dichotomy. So there are 2 voles. They look very similar. I couldn't tell them apart. One's the prairie vole, one's the montane vole. One is highly social, lives in communal burrows under the ground with his family. Biparental, the male does 50% of the child care. 80% of them will mate for life and won't accept a new mate. And if one of the litter is attacked, there's a high ultrasound distress call from the male. Now, the montane vole, on the other hand, lives all by himself, gets together just to mate and then leaves, is not aggressive to intruders, really doesn't care much about the rest of the litter, low separation distress from litter mates, although high separation distress if he's threatened. And there was, remember Temptation Island? There was a TV show. So Temptation Island was, they put someone on an island, a male and a female, to see if they were going to cheat on each other. But anyhow, my temptation island was they had a female on this side of the cage and his wife on one side of the cage, and he would ignore them both equally. So anyhow, the difference between these two voles is their oxytocin receptors. They have markedly different oxytocin receptors in different parts of the brain. And so all of their social stuff is so different. So the thought that oxytocin might be very important in autism because of the social issues. Now, the studies I did mostly, of course, were these are I think rats, this is the way rats do social recognition. So, you know, take it for what it's worth. This isn't the same as human socializing, but you could see the social. So what this basically means is each time the white is a typical rat, and the blue is the blue is a typical rat, and the white is, they knock out the oxytocin. And so each day, if there's a female in the cage, he recognizes her, and he spends less and less time sniffing, because he knows already it's cool. The oxytocin rat spends exactly the same amount of time sniffing every day, as if like he doesn't know who this other rat is. And the other half of that, you could see that other things besides social were equal, whether you have oxytocin or not. So there's a whole lot of things that we've learned about oxytocin since then. The first autism study was done in 2006, Eric Hollander, who was at Mount Sinai at that time. And he gave oxytocin and placebo, and they taught a social skill to some Asperger-type patients. And they both improved that day. They both learned some social skills. But a week later, the ones that got oxytocin still remembered it, and the placebos didn't. So everyone was very excited. The second paragraph I took from a review paper in 2016. So oxytocin optimizes these circuits, meaning all these social circuits, reward and motivation and learning to improve therapeutic outcomes. Despite this, there's no evidence it does anything good for autism. So people are still very excited by oxytocin. They're still doing trials. But so far, nothing has really panned out for autism. And that's, again, I think, because we don't really understand what we're studying. You know, again, you can't take the rats and just say, all right, no, let's assume that human social is the same thing as sniffing. Okay, so this is, now I'm going to get to a part of the talk which is what I'm most interested in. This is kind of like my work, not the baby work, but other work I do. So the first thing I want to say is, we talk about neurotransmitters, but there really are two different things. One's a neurotransmitter and one's a neuromodulator. So a neurotransmitter sends a signal from one cell to the next. So if you look at something, the light goes into your eye, your neurotransmitters send it back to the occipital lobe, and then, okay, you're sending a signal. Neuromodulator kind of controls what I call the gain of several circuits. It's an electronics thing, tuning them on or off, stronger or weaker. So most of the chemicals that we play with in psychiatry are really not neurotransmitters, they're really neuromodulators. So, and this is just a visual of, you know, a neuromodulator, you know, with all the dials and all the things you can do to make the brain function correctly, the neuromodulators do. So, can you see that? Because I wanted to get a little idea of what I'm talking about. So locus ceruleus, this thing here, that's about 90% of your norepinephrine, which is the neuromodulator I'm most interested in. It comes from there. That other big thing there, the lateral, that's about the other 10%. And it goes all over the brain, but the places that they've outlined are where it's most important, the amygdala, hypothalamus. So the amygdala is the part of our brain that mediates mostly emotion and fear. So when you go into a rage, it's because your amygdala is saying you're in big trouble, you better go crazy. The hypothalamus is the part of the brain that mediates all of your hormones. You see the cingulate gyrus there, that's a part of the cortex that assesses things and makes decisions about what you should be doing. And this is the cerebellum. Okay, so I just wanted to give you a little bit of an idea of the anatomy of this. So the locus ceruleus gets messages, regulated by other parts of the brain. Now it gets direct inputs from the brainstem nuclei, and that's really the control of primitive behavior and your autonomic functionings. So this is primitive stuff. This is like reptile stuff. Reptiles have the same nervous system, this part of the nervous system. Oh. I don't know why it went away. Oh, it's back? Okay, so so this is reptile stuff. So now, what's the opposite of what I'm calling reptile stuff? It's the cortical stuff where you could think things through. So the other parts of the brain that influence the locus coeruleus are and as you see up there, the anterior cingulate and the orbital frontal cortex. So those are parts of the brain, especially the orbital frontal cortex, that's really big in humans and no other animals. So when the humans evolved, so mice have almost no orbital frontal cortex. Rats have a little bit. Monkeys have even just a little bit. Apes are doing a little better, and humans are much, much bigger. So for most of what we do as humans, the orbital frontal cortex is really what makes us more successful than those other animals. And there's a lot of evidence in autism that the anterior cingulate and the orbital frontal cortex don't function well in autism. And so, yeah, it's written here. I wish I had a pointer, but it's not working. The anterior cingulate cortex and the orbital frontal cortex. Well, the orbital frontal cortex is right in the front. The cingulate's kind of a little back. Yeah, okay. So what happens? So let me try and paint a little picture. So you hear a big sound. Okay. Now your lower centers, your reptilian centers, go, let's get out of here. You know, this is danger. You know, your orbital frontal cortex says, no, that was down the block. Stick it out. Let's see what's going on. Maybe it's nothing. Maybe it was a car backfiring or something like that. And so most of us, when we hear a big sound, don't jump on the ground and run away. Okay. Now the reptilian stuff is much more powerful. So we have to overrule that all the time. So in our day-to-day social life, how many times do you want to punch someone in the nose, right? If you have a good orbital frontal cortex, you don't do it. If you're very reptilian, you're going to do it. And one of the problems we probably have in autism is that those brain centers don't function well, and maybe they don't function in time. So sometimes the autistic kid just pops off and misbehaves before they even have a chance to quote unquote think it through. And that's really what this is about. But not only is it about that, but it's stimulating the locus coeruleus. And you'll see why I care about this in a second. Yeah, well, I'll get to that. I'm just introducing the topic here. Okay, so, and this is a slide about the regulation of the locus coeruleus, and it's pretty much what I've said. It gets the lower functioning, where that green thing is, the NGC, but also from the PFC, the prefrontal cortex. Okay, so this graph, if you look at the bottom, this is the firing of the locus coeruleus. By the way, if I didn't make it clear, locus coeruleus is where norepinephrine comes from. Norepinephrine goes everywhere in the brain. Okay, so what happens there is there's what we call a tonic firing. It just fires anyhow. It goes on all day. But when it gets triggered, then you see that one big spike where it said light on? So this was a task, I think this was in a monkey. They put the light on, and then the monkey was going to act. And so it got this big hit of norepinephrine. And that's called a phasic response. Okay, a little small, but I think we can. So where it says go, that's the equivalent of the light going on. But you see that The spike doesn't come till a little bit later. And that spike, and then you see this little hand up there. Basically, what I'm, the point of this slide is that you won't act unless your locus coeruleus tells you to act. So you'll get the stimulation gets processed, but you won't act on it until the locus coeruleus says, okay, act. So it's very, very important. Now, these are some of the neuroadrenergic functions that we're interested in for autism. So one is attention. So, and I'll talk about this a little more in a couple minutes. In order to pay attention, you have to decide what to pay attention to. You need the locus coeruleus for that. Transitions. To act, you need to stop what you're doing and to do something else. You need the locus coeruleus for that. Autistic people are famously bad at transitions. Okay? Valence. So valence means the amount of emotional weight we give to something, and I'll talk a little more about that too. Valence is something that also gets built by the locus coeruleus's input. So in other words, the locus coeruleus tells us when we should care about something and not care about something. Learning, including social learning, sleep, which I'll talk more about, something called reconsolidation, and language acquisition. So if you think about all these things that I outlined, this is really a big hunk of what are the things we need to deal with in autism. And it's all related to the locus coeruleus. Okay, so I don't want to get too technical. The only way we have easily of monitoring locus coeruleus is pupil dilatation. There's a good correlation between your pupil diameter and the functioning of the locus coeruleus. And there has been studies that autistic people have greater pupil dilatation, 1 to 1.2 millimeter greater in 2 to 6 year olds. And so what that means, I think, is that the locus coeruleus is firing too much. I think it's firing too much tonically. So you're getting a lot of noise. And this could diminish the phasic response. So in other words, when there's too much noise, it's hard to hear the signal. Am I everyone clear about what I'm saying? Okay, so these are theories that are being bandied about in the neuroscience world. And so, so the pupil is, all right, let me skip this, I'll move on to the next. So, one article reported that during the viewing of a novel scene, typical adults showed an initial scanning phase characterized by shorter fixation durations followed by a subsequent phase of longer fixation durations. Okay, that sounds very boring, but it's really very easy to understand. So what happens is when you go to a new place, like you walk into the room, I've never been here before, so I walk into the room, what am I looking at when I first walk in? Well, I'm looking at everything. I'm in a scanning mode. And this goes back to my days as a rat or a reptile, whatever I was in previous lives. And you're looking for predators. When you go into a new place, the first thing you really need to do is, are there any predators here? Okay. Now I go into the room and, oh, I see someone over there. Oh gosh, I owe that guy money. Let me turn around. So what happens is you start to scan and you start to evaluate what in the room is of significance and what in the room is not of significance. Now you do is, so you give a little bit, but then when I see the guy who I owe money to, oh, is he looking at me, you know? Is he going to remember I owe money, you know? So what happens is you start to focus on certain things which you care about. Okay, and this is probably what the autistic people can't do. So and there's actually some evidence for that. So because when they scan, they can't decide when to focus, they probably stay more in a scanning mode. And when they do focus, they tend to over-focus. And sometimes it's called stickiness. It's hard for them to make it stop. So here's my theory. So in autism, the neuroadrenergic system is dysregulated. And I wrote in the second bullet, that doesn't mean too much or too little. It's not too much, it's not too little, it's both. Sometimes it's too much, sometimes it's too little. But it's not at the right time. So when you walk into the room, you're supposed to scan, look around, and then decide what to pay attention to. And they can't do it like that. So they might stay in a scanning mode the whole time they're in the room. Or they might get stuck on one, see, and then they can't put the rest of the things in the room in context because they over-focused. The timing, of course, is key, especially in social situations. In social situations, as opposed to, say, reading. When you're reading, you can read it, put down the book, you pick it up, read, and you'll get the gist. In a social situation, it's gone. Once a person said something, they don't keep saying it. And so you can't learn social cues unless you're paying attention to those social cues at the right time that the social cues are happening. So I wrote that the treatments at this point, and that's your question again, the treatments at this point are crude, but they could get better. So we have adrenergic drugs, and I'll talk more about the adrenergic drugs, but the adrenergic drugs can only either make it more or less. It can't make it always go in the right direction. Because you probably need, now I have some patients that are probably way too much. So some of my very aggressive patients probably are too much noradrenaline too much of the time. So by lowering it with an anti-adrenergic drug, I'm probably making them closer to normal. But it's still not necessarily going to help them pay attention to what they need to pay attention to. There are treatments that are being played with now. One of them is transcranial magnetic stimulation. I have a friend in South Carolina who's actually doing it, claiming success. He's published on it. There's actually we're putting in a grant now. I'm working with some people at Columbia, and we're trying to do deep brain stimulation to actually have neurosurgeon sticking electrodes in. We're not anywhere near up to this level of sophistication. We're looking for some very self-abusive people but if we could have deep brain stimulation, we could help them stimulate their brains at the times when they need to pay attention, things like that. And the optimal functioning of the locus coeruleus is an inverted U-shaped curve. So here it is. So you see if it's too little functioning, too little activity, you're kind of out of it. You're kind of in a daze, maybe call it lethargic or whatever. At the top of the curve, that's when you're doing your best cognitive work. You're really chugging there. When you go too far to the right, you become too hyper, too anxious, and then you can't pay good attention. So what we need to do, and what typicals can do, is they kind of force themselves into the top of the curve when they need to. So if you have a bunch of neurotypical teenagers, before the teacher comes in, they're jumping up and down and screaming, and then when the teacher comes down, they can calm themselves down and go back into the appropriate level of arousal. So the adrenergic blocking medicines, they lower arousal, they can treat aggression, self-abusive behavior, and hyperactivity. They're generally FDA approved as antihypertensives. They're blood pressure pills mostly. And they include 10x, clonidine, and the long-acting forms of those two, which are Intuniv and Capve. Then there's propranolol or Inderal, which is a beta blocker, and that's actually the one I've been studying. And I'll talk more about that. I have some pretty exciting results with the Inderal. And the last one I put up is prazosin, which I've used a little bit, and there's not much. I may be the first one to use it with autism, so there's nothing in the literature about that, but it is being used for post-traumatic stress disorder and fear. Okay, so the 10x, I made a 10x slide. I didn't make a clonidine slide, but 10x and clonidine are very similar. So these have been used for years in attention deficit disorder. A lot of the kids are on stimulants, but they can't use them at night and because they won't sleep, and so they use 10-hexaclonidine, which kind of helps them calm down and also pay attention later in the day. They've had some double-blind trials in autism, and they were moderately successful. And the last one, Scahill et al. Did a study in Tuniv, the long-acting 10X, and found a 43% reduction in hyperactivity. There's also been literature on neurotypicals, and I think ADD, that 10X actually helps cognitive functioning. It makes people perform better on cognitive tasks, learning. It's never been tried for learning in autism. So this is, all right, so I have this link here, and my computer did it, but this computer's not letting me link to it. I'm sorry, I can't show you that slide though. Okay, so I'll tell you what it says. So I have a case series of about 45 very violent or very self-abusive autistic people, and I used very high doses of Inderal. 80% of them got much better. And these are people who were tried on an average of 6 different medicines before the Inderal. They're almost all also on antipsychotics. And if I took away the antipsychotics, they didn't do well. So it treats the aggression very well. It treats the self-abuse very well. It does not help hyperactivity or repetitive behaviors. Okay, so it seems to be very specific for aggression. Okay, remember I told you that the locus coeruleus stimulates the amygdala, and the amygdala is what makes us go crazy. So it might have something to do with that. Another theory is, and this is, I'll relate this to post-traumatic stress disorder. So for those who don't know, post-traumatic stress disorder, any trauma, it could be soldiers who come back from war, it could be crime victims, it could be motor vehicle accident people, anyone who's had a really terrible trauma. What frequently happens is you can't get rid of it. You keep having that memory over and over and over again, and anything that reminds you of that sets you into a very severe state. And it could be an anxiety state. It could make you aggressive. So here's the theory that when you have a memory, let's say the memory of your trauma, you bring it up, and it becomes what we call labile. So the memory is up there. Okay, so I think a good analogy would be, let's say you're an antelope, and you're thirsty, and you go to the watering hole, and you're drinking water, and here comes a lion, and the lion chases you, and you get away. Okay, now that was really scary. Now the question is, what do you do the next day when you're thirsty? There's only one watering hole. And you don't want the lion to chase you, but you really are thirsty and you don't know what to do. So what you have to do is you have to go back to the watering hole and you have to test it. And if you go back to the watering hole and the lion's not there today, you take your drink and you leave and you say, well, that's pretty good. I got the water and the lion didn't chase me. And then, Okay, post-traumatic stress people can't do that because when they think of the trauma, they get into a state and they get paralyzed and they can't. Okay, so what the antelope did in that case we call reconsolidation. You alter the memory. You say, well, this watering hole is not exactly safe, but it's better than dying of thirst. So you modify your memory, you modify your perception, and you work with it. A post-traumatic stress person can't. And I think the autistic people can't. I think the autistic people get thoughts in their head and it sets them off. I'm talking about my people who are very aggressive. Because a lot of what triggers them, we don't even know what triggers them half the time. It's something very minor, but they get really wild and they're super strong and their autonomic systems are pumping. And and some of these people are on 5 or 6 medicines, and it still doesn't seem to stop them. But the Indoral seems to stop them. And the theory is that by blocking the neuroadrenergic system, you're allowing them over time to reconsider whether every time they hear that sound they have to go crazy. And so I think that's why it's working. I have a grant now to study the Indoral double-blind placebo control, but I would like to also see if I could prove some of these theories. Okay, salience. So salience means a stimulus that attracts attention to the observer, and the observer feels compelled to approach. Something that's salient is something that really grabs your attention. So this is what's salient for an adult male, and that's what's salient for many people on the spectrum. Now, how did that come to be? Well, it came to be because let's deal with Elmo first. When Elmo gets on there, the person felt reward and pleasure. And that taught their brain that this is something really good. And I guess you can imagine why that became salient. So the salience is plastic. In other words, your brain state makes things more or less salient. So for example, you probably heard that you shouldn't go shopping when you're hungry, right? Because you'll buy all the garbage because you're hungry and everything will look good. So you should have a big meal and then go shopping. You say, we don't need this, right? So when you're full, you don't care that much about food. The second paragraph, I talk about female bird songs, and I'm going to talk more about bird songs. In the winter, when it's not mating season, the females don't even want to hear the male song. It's completely uninteresting to them. But if you give her a hit of estrogen, she'll start pressing a lever so she could hear his song. And she really likes it. And with the placebo, and she'll press the lever hundreds of times because it's very salient. Whoops, I blew that joke. I was going to ask you, what does he make you think of? And then, this is like salience, but it's a slightly different concept. It's something that we might call overlearned. So when you have like if I say, I'll give you a different one. I say the word pen, most of you will think of the writing instrument. Most of you won't think about a pick pen because your brain has practiced that pen is this thing. So your connections are stronger and stronger and stronger. Now, both for the kind of emotional salience I was talking about and for cognitive salience, again, these are both neuroadrenergic functions. It's the neuroadrenaline tells your brain what to focus on. And so that's how you've learned. And so you've established that a pen is something you write with. You've established what makes you excited. And you live with that because you've trained your brain for that. But that, again, is a neuroadrenergic function. And if we alter the neuroadrenergic functioning, you can retrain your brain either to focus on different things. So the autistic person who's very repetitive, who just wants to do the same thing over and over again, if you knock down their norepinephrine, they might be able to get off that track and create new tracks, which is what I think would be crucial for learning. Okay, so here we have a songbird. And the reason why we're interested in songbirds is they're the best model for language acquisition of all the animals. Why are they the best model? Because you wouldn't think birds would be a good model for a human brain. It takes place during, they learn their song just the way we learn language during a critical developmental phase. And they have to do sensory motor practice. It relies on a social interaction. A bird won't learn a song in a vacuum. So in other words, they have tutors. Now, usually it's a male bird with the father. The father teaches the son the song because the song is really to attract the female. So, you need a tutor. Now, of course, humans don't learn language without tutors, so we have to teach our kids language. It requires special brain circuitry dedicated to the development of hearing those sounds and then refining the sounds. So the father sings this song to the son, and the baby bird has to practice the sounds using auditory feedback. And when the baby bird first starts to sing it, he doesn't do very well. And it's like baby babble. It's like human babble. But as he practices and he listens and he refines it, the song gets better and better. Okay, and the father bird also changes his song structure to teach, and we call that in human terms motherese. So you know how mothers talk to their babies? Oh, baby! See, we don't talk to each other like that, but we all talk to babies like that. And the father bird actually slows down with bigger gaps between the syllables and teaches the bird. So this is a really, really good model for the way we acquire language. And now, why am I interested in this? Well, because there are two chemicals that if they're not in place, the bird won't learn the song. And one of them is norepinephrine again. And the other one is estrogen. So it's possible, again, so one of the real interesting issues about autism is why do our kids not develop language? Or if they do, the language is impaired, or mostly impaired. Why? You know, I mean, there are people with, say, like Down syndrome could have pretty low IQs, and yet their language is pretty good. Well, I think, again, it's the norepinephrine. I think that the norepinephrine is too high and it's not allowing them to process language. So it's actually been shown that the norepinephrine, what it does is it has to lower the tonic firing so that they can hear the sounds better. And that probably too much norepinephrine, again, or dysregulated norepinephrine, doesn't allow them to learn the language the way they need to. Now, then there's attention. Attention consists of three independent things. Alerting, which is just your state of alertness. So when you're not alert, right, you're sleepy, or you're kind of out of it, you're staring out, right? And then but let's say you are alert, but then you still have to orient to what's interesting. And then the third one is called executive control. And executive control is kind of your putting this sensory stimulation in context, both externally and internally. So your executive functions tell you what this kind of means. So an executive function might be you're listening to this lecture and you're accepting me, I think, as an expert. And so you're saying, okay, well, I'm going to listen as if this guy knows what he's talking about. Whereas if you were at a cocktail party and someone starts telling you all about autism, you might say, well, I'm going to turn it off, because your executive function would put you in a different context. So those are three issues of attention. Okay, so from birth to 1 month, infants have a difficult time disengaging. So once they pay attention to something, if you're less than 1 month old, you just stare at it. And you really can't do much. But once you hit 1 month, you begin to get better and better at tearing yourself away from that stimulation. And then, as I was talking about before, scanning, looking at different things, making decisions what to pay attention to. A typical kid hits his adult levels of disengaging at 10 years of age. So once you're 10 years old, you're just as good as an adult at doing that attention, disengagement. And these involve, and for the development of different things like processing novel things, arousal, joint attention, social attention, all the things that we need in autism. We published a paper in 2010. We had 2 screens. One screen was just having light flashing at a very fast rate, and one had light flashing at a very slow rate. When the kids were 4 months old or younger, everyone looked at the high frequency stimulation. At 4 months, the typicals started looking equally at the fast and slow. The autistic people never stopped looking at the fast. Even autistic adults will be preferential to the fast stimulation. So there's something about the inability to make, again, that decision about what to pay attention to. You know, from an adult point of view, a slow frequency and a fast frequency are both equally interesting. This is I'm blanking out on the name of this. Theory of mind. Theory of mind. Do you all know about theory of mind? You do. Here. Anyone? Should I talk about theory of mind? Okay, it's moderately interesting. I know it's getting late, but so this is little Sally there, and she's putting a marble into a basket, and then she leaves the room. And then when she leaves, her friend Anne takes the marble out of the basket and puts it in the box. Now, Anne leaves the room, Sally comes back in the room, and the question is, where should she look for her marble? A typical 4-year-old will say, in the basket where she left it. Autistic people, even older autistic people, can't do this. They say, well, in other words, they can't seem to understand that when the person leaves the room, they're going to come back with the same understanding that they left the room. And this is a fascinating problem, and psychologists have been studying this for a long time. And it's called theory of mind. And one of the corollaries to this is that autistic people don't really realize that other people have minds. Does that make sense? And the reason why that, because they've done other experiments where if Sally left the room but took a picture, then she would, if it was a camera, if it wasn't Sally, if it was a camera, if they said that you took a camera picture, where would the marble be? The autistic people get it right, because they kind of know what a camera would do. Well, the camera will take the picture of where it is, but the girl who leaves the room, her mind won't be like the picture. It won't. And again, this is a function of executives, partly due to executive functioning. Again, it's probably something to do with the norepinephrine turning on and off the right circuits for attention. And this is sleep. This is the little sleep segment of my talk. And so you see that's what the locus coeruleus looks like when you're actively awake, and then as you get drowsy. And there's one point in sleep when the locus coeruleus is supposed to turn off completely, and that's REM sleep. So during REM sleep, you're supposed to have no functioning of the locus coeruleus. It's the only time of day. And there's been some really good studies. This is one from Buckley, 2010. There's another one that's not yet published, but I heard her talk. Her name is O'Hara from Stanford. She got the same results. Autistic people sleep shorter time, greater slow waves, but much smaller REM sleep. And now, forget the rest of the slide for a second. There's another very interesting thing about sleep. Do you know that you learn when you're asleep? They've actually done really good experiments, and they teach you something at 5 o'clock, and then at 6 o'clock they test you on it, and you do however well you do. Then you go to sleep and you wake up in the morning and you do better than you did at 6 o'clock. And it's not just because it's a few hours later, because they've tried this like at 9 o'clock and 10 o'clock when you didn't sleep in between, and then they tested you like 8 hours later and you didn't do better. So it's been proven that what happens is during sleep, your brain forms connections. And the theory is that to form these connections, your norepinephrine has to get out of the way. It's kind of like what I was talking about before, reconsolidating. If there's too much norepinephrine, you don't learn. So this may be one of the causes of the learning problems that our kids have. Okay, so the end of this, let's see, we've got 9 minutes. The end of my talk is just general stuff about different things. If you want to ask questions now, you can, or I can just go through the rest of the slides. Yeah.
A lot of people have been telling me, as far as vitamins and minerals, that magnesium is very important. When their children were aggressive or their children were more anxious, that they were using magnesium and that they were seeing a benefit.
Okay, so I mean, I don't know if you guys you remember Bernie Rimland?
Mm-hmm.
Yeah. So he was pushing B12 and magnesium.
Yes.
Never saw it work. Like everything else, and what I actually, so in this slide, what I put is, you know, some of these things, the gluten-free, casein-free diet, by the way, I don't know if any of you have done that. That one's actually been well studied, and it didn't work. It was really didn't work. Huh? And
I believe there is correlation only if there is some gastrointestinal.
well, yeah, if you have gluten
Yes.
enteropathy, that's
Yes.
different. That's different. Then you're treating gluten enteropathy. You're not treating autism. Yeah, I mean, look, any reason for a stomach ache, you should treat you should treat the stomach ache. You know.
But as
Yeah,
far
but
as
with
autism, there's no benefit.
No, so the research that was published initially, all of everyone in the sample already had the gastroenterology and autism and the diagnosis when they went into the study and it was published.
Yeah, well, look, you know, if you have gluten enteropathy, you probably have diarrhea. And so you go to the GI guy, and he diagnoses you, and he takes you off gluten, and there's no problem with that. It's, you know, no one's arguing that. But the study on autism were not people who have gluten enteropathy, and the diet didn't help. Some of these treatments are safe. Many of them are probably safe. Some of them are not. Sometimes they tell you to take vitamins that are actually in toxic doses and things like that. Or sometimes people get put on restrictive diets. I have a friend in Rochester who studied this, and she studied kids. She actually ended up doing a gluten-free, casein-free diet. But when she took kids who were already on that diet, their vitamin nutrition was very poor because they were probably on restrictive diets, and autistic kids also put themselves on restricted diets. And so then if you keep restricting more and more things, you may not get good nutrition. So, you know, my advice is evaluate the risks and benefits. You know, a gluten-free diet is not going to hurt you. It might make the kid unhappy if you can't eat cake anymore with it. Although nowadays they have gluten-free everything. So. Anyhow, a lot of my patients want something natural, and being a wise guy, I always tell them arsenic is natural. But I'm only half joking again. The medicines that are studied for safety. The natural products that you use are not studied for safety. There's stuff in health food stores. There was one, I think it was Kava Kava, that everyone was using for depression a few years ago. And then they started noticing in Germany that people on Kava Kava had high rates of liver cancer and things like that. So just because it's natural and it's an herb doesn't mean it's safe. And, you know, so, you know, I'd be careful with these things. And then there are some treatments that are just downright crazy, not safe. You know, this is an old slide. Any of you remember IVIG? You remember the good old days. They were injecting immunoglobulins into the autistic kids, thinking that it was going to bind up some bad proteins that they had. It's a very dangerous thing. Something like 10% of them, you're increasing your risk of hepatitis by 10% or something like that. And there was no evidence that it worked. Chelation, that was under the theory that, you know, everyone had heavy metals and that, again, that's dangerous. There was something called holding. Holding, what it was the teacher would lay on the kid and squeeze him, and then talk to them and teach them, and that was getting popular until one of the kids suffocated. And then, of course, there was no evidence that this worked. Now, I could justify why holding would work from the norepinephrine because, the squeezing probably calms down the autonomic system. That's like why Temple Grandin likes to be squeezed, but that's not the way to do it. I wrote in here indiscriminate ABA. I think ABA is great. I think everyone should do ABA, but indiscriminate ABA gets crazy. And I heard one case where someone was acting up in a very strict ABA school, and they were squirting vinegar in his mouth as an aversive, and then his appendix burst and he died. And they just took it as a behavior so you have to, use judgment. You can't just apply treatments indiscriminately. Advice to clinicians. I've given this talk to doctor groups and things like that. And I always tell doctors, represent rigorous science, because you're a doctor. I mean, if somebody wants to read the internet and try things in their kids, they could do it, But, you have to represent things that have some evidence, and you could explain, as I said before, just because it hasn't been tried doesn't mean it doesn't work. So people have to make some judgments, but you should be representing the science. Explain yourself, don't assume too much. There's crazy ideas out there, on the internet and everything. You'll read stuff and it just makes your head spin if you read some of this stuff. And doctors just assume that you're thinking like they are and you're reading the same literature. So, sometimes you have to start from scratch and explain things. Stay current, be aggressive about early diagnosis and refer to early prevention. This is, in the old days, I don't know if it's still the case, but pediatricians were loath to make the diagnosis too quickly, and they weren't referring people in a timely fashion. Start low and go slow. That's for medicine doses. That's for all children anyhow. Make only one change at a time. I've always lived by that rule, and sometimes frustrate the parents because they want relief now, but I always urge them to, look, you'll thank me. In a year, you'll thank me. Not this week. And together with parents, be clear about the targets. As I was trying to explain, some of the medicines will hit some symptoms and not others. So if I give Indoral and your kid's not violent, but he's still running around circles, you don't call it a failed trial. It still helps something. So you got to know what your target is, and maybe we need something else for the hyperactivity. And try to understand the needs of the family. There was one 2-year-old I once gave. This wasn't even. I gave a 2-year-old a stimulant because he was really hyper. And the reason I gave it to a 2-year-old is because he was attacking his baby brother. So he was like jumping on the baby brother in this hyperactivity. And, the mother was saying, if I turn my back, he's going to kill him. So give him something now. And, so, I medicated the kid even at age 2 because of the needs of the family. Regular 2-year-old, you could let them run around in circles. Okay, advice to parents. Respect the clinician's knowledge despite the fact they don't know everything. And you don't have to follow their advice. But a lot of doctors know a lot about narrow areas. So that's why I say, you got to go to a neurologist because they treat seizures all day. And even though in my life, I've treated maybe 100 people with seizures, and I kind of know what I would do if I was a neurologist. I'm not a neurologist, and so those guys know even more about that. But, there are plenty of things I don't know about, and that's just the way it is, and it's true for everybody. The definitive treatment does not yet exist. And I've had patients who packed their kid up and flew to California to do a treatment. And what I tried to tell them is, look, if this guy has the treatment, he should just publish it and let us all do it. Is he the only one that wants to do this treatment? Right now, if it sounds too good to be true, it probably is too good to be true. Treatments can be viewed as complementary, and a lot of professionals get into that, and I think some of the behaviorists are the worst. There are behavioral schools that don't let people use meds, which I think is kind of criminal. consider the whole family again. And accept small improvements with gratitude. When I brought my son to a doctor once, and he said, "How's he doing?" I said, "Oh, he's terrible." And then he said, "All right, well," and I listed 2 or 3 things that got better, and he said, "Accept small improvements with gratitude." It took me aback, but it was really, really good advice, because it's how you frame your outlook. And I really do believe the kids pick up on our attitudes. And so if your attitude is, if you're on edge, if you're hopeless, if you're down, the kids are going to pick that up. If everything's okay emotionally, the kid will start to get happy. So, adopting an attitude of gratitude is a really good thing. Okay. Well, that's it. I think I just came in on time, huh? Oh, 2 minutes
Yeah,
left.
my son was put on anti-anxiety 3 months ago, clonopin, because you didn't touch on it.
Yeah.
So because he's anxious, but he also had mood swings. So a while ago, you mentioned the mood stabilizer. So how do we know if he should be put on mood stabilizer or anti-anxiety med?
All these kids are individual, and I have my own list of things to try for different problems. And some of it is just gut feeling. Sometimes I look at a kid and I say, the kid just looks like he's going to jump out of his skin. And I say, well, this kid needs to have lower arousal. And so I'll do something to lower arousal. Sometimes the kid looks perfectly calm, and then he gets up and hits me, And that's not the same kid as the one who looks like he's going to jump out of his skin. So, I've developed my own sense of instinct about how to try things. In the end, though, it's really trial and error. If something works, it works. If it doesn't, whoever's your doctor hopefully has experience and, has had experience with things that worked.
Because now I'm thinking about it, I think we should have tried mood stabilizer instead of anti-anxiety.
Yeah, I can't comment on your kid. I never met your kid,
Mhm.
so I don't know.
But how's clonopin? Is it effective with our population?
I use Klonopin. I didn't put up a slide for the benzodiazepines, but I do use them, yeah. Sometimes for kids who are hyper, for kids who are hyper aroused. I mean, these are anti-anxiety tranquilizer type pills, and they're safe. They're nice, very few side effects.
Questions?
Okay.
Thank you very much. Thank you, everybody. I appreciate it.